And Tiziana, one of the issues with small cell is they tend to have more, paraneoplastic, syndromes. They're biologically different than the non-small cell lung cancer. What's your experience with in terms of what happens to paraneoplastic syndrome? What are the autoimmune toxicity profile of patients with small cell that you've treated?
Yeah, I think certainly when we started using combination of chemotherapy and immunotherapy or immunotherapy as monotherapy, we had the concern that in these patients that had higher rates in general compared to other kinds of cancers, although still rare, to have these paraneoplastic syndromes, would we get worsening toxicities? Would we get worsening immune-mediated toxicities? My own clinical experience has been that the paraneoplastic syndromes are not significantly worsened by using immunotherapy. Really, it has been a driver mainly of the disease itself. Certainly, when patients present with more debilitating neurologic paraneoplastic syndromes, I find that it's difficult to really have patients recover fully. And I frequently have a multi-D team with neurology, and a lot of these patients are receiving IVIG. And so then the immunotherapy question becomes difficult, and I think we have limited data to really say what really will benefit that patient. So I tend to back off if they really do require immunosuppression and really try to focus on the chemotherapy and trying to reduce the burden of disease and seeing if there's clinical benefit with control of the disease and improvement of the paraneoplastic syndrome. Now, whether the patients who get paraneoplastic syndromes and receive immunotherapy, whether they have higher risk of immune-mediated toxicities, I guess I don't know that in my own clinical practice I have enough to say that one way or another, but I'm interested in hearing from others if they do have thoughts about that.
I would say my experience is a little biased towards combination therapy, and as would otherwise be expected, the autoimmune complications are significantly higher.
Combination PD-1, CTLA-4.
PD-1, CTLA-4. And the patients are sicker in general, so they are less equipped to recover from such complications.
Yeah, my experience using these agents is that while autoimmune-related toxicity in general tends to be higher, I've not seen unique paraneoplastic syndromes that we've come to associate with small cell to appear at a higher frequency than you otherwise would have expected. Now, having said that, we also know that paraneoplastic syndromes tend to be commoner in patients with relatively small burden of disease with limited stage. So perhaps as we now go into the limited stage setting with this agent, we have to pay more attention to the possibility of seeing more of the paraneoplastic syndrome in that setting. But I've not seen a lot of it in the extensive stage patient. There have been a few patients where I've seen a bit more of CNS toxicity than I've seen with non-small cell lung cancer patient, and it's unclear to me whether that is direct treatment-related toxicity or just the way the patient would have behaved. But it's unique that the two of them, the two patients I have, who came with really, really severe cerebral dysfunction, both of them got combination CTLA-4 PD-1 or PD-L1 agent.
Yeah, I've seen it both with single agent PD-1 and combinations, and it can be very subtle. Neurotoxicity only manifests as like a little bit of gait disturbance, a little bit of memory dysfunction. Sometimes it's hard to tell whether it's from their PCI or just being sick, but I do get the sense that there's more neurotox in these patients, so just to be cognizant of it.